Coniero, and I'm the CSO of CTF Europe. I wanted to welcome you to this info masterclass and most especially thank you on behalf of all the patients for your interest in NF. Now, before we move on to the real stuff, I need to give you some instructions regarding the Q&A. You will be able to put down your questions by using the chat box during the masterclass. We would much prefer if you put down these questions in English. If you have trouble formulating your question in English, we could advise you to try to use online translators such as Google Translate before putting them down in the chat box. And if that is not possible for you, please do it in your own language, and we will do our best on our end to have it translated as best as we can into English. Enjoy your masterclass.
Good evening. I'm Dr. Susie Henley, clinical psychologist at Guy's and St Thomas's NHS Foundation Trust in London in the UK, and I'm going to be talking about emotional challenges in NF1, NF2 and schwannomatosis. So I'm part of the National NF Centre at Guy's and St Thomas's. This is a lifelong service for people with NF1, NF2 and schwannomatosis. It's highly multidisciplinary and we try and offer holistic care. We look after people through the whole lifespan, but the psychology service itself is for patients who are age 16 or older. And for this presentation, I've collaborated quite closely with Dr. Thomas Plechko and Dr. Verena Rosenmeyer in Vienna. And they also offer a lifelong psychology service to people with NF, and they have particular expertise in younger people, family work and neuropsychology. So between the three of us, we cover the whole age range of NF, and that's what we're trying to cover in today's talk. We've also worked really closely with a lot of our patients to make sure their voices are heard in this. Emotional challenges and mental health problems can often be very hidden, and we may not know about them unless our patients trust us enough to tell us. So throughout this presentation, I've put in quotes and experience from patients to really show what their experience is and to drive what we're trying to offer them and how we're trying to help them. And just to set that off, here is a wonderful painting done by somebody with NF2. This is someone who had some surgery for NF2 and the surgery was needed, but this person was left with a lot of deficits after the surgery, and this is their way of portraying how this has left them feeling and what's happened to them. And I just want to highlight the words here, taken apart is how this person feels after that surgery. So I think that's a really powerful way to start this presentation, just to hold in mind that these conditions can have a really big impact on the mental health and well-being of our patients. And here are some quotes to start us off as well. So this patient who has NF2 says, "As well as managing the hormones of a typical teenager, I was managing the confusion of hearing loss and the fear of the surgery. So I rebelled against everything I could. I became an angry, unruly teenager. I refused to talk to anyone about my health in any way." Here's somebody with NF1 saying, "I feel like every time I reach a milestone, NF pushes me back." Someone else saying, "I keep thinking my life will never get better." And someone else kind of demonstrating a really common issue with these lifelong progressive conditions. "I know the doctors have said my brain is fine, but it's always there. That what if it grows? What if something bad happens?" And so before we move on to think about specifics, I just wanted to set the context a bit and think about why we're even talking about mental health in a physical health condition. So you can see here some information from King's Health Partners, an organisation in the UK that gathers data on this. And you can see, for example, that 30% of people with a long-term physical health condition also have a mental illness. And in the UK, and I imagine this is mirrored elsewhere in Europe, £8 billion a year is spent by our health service treating the effect of poor mental health on physical illnesses. So perhaps we think we have a moral duty to try and help people, and alongside that there's a financial cost if we're ignoring mental health problems in people with physical health problems. And this is just a way of trying to break that down a little bit. So we might see people where their mental health problems seem really quite independent of their physical health. But we might also have people where their mental health problems can be driven by physical health. So a very clear example is people with chronic pain might also feel more anxious and more low in mood than people who don't have that chronic pain. And then we might also see people where their mental health problems could be exacerbating physical health issues. So for example, if someone's physical health, they've been recommended to do some exercise or engage in some physio, but they're very depressed, they might lack the motivation and the strategies to engage in those activities that would otherwise help them. So particularly when people fall into these two categories, addressing mental health issues can improve outcomes for both mental and physical health. So we know a lot about the prevalence of mental health difficulties in the general population, globally as well as in individual places. So globally, on average, 1 in 5 people are likely to have a mental health problem at any one time. And in the general population in England, women have a higher lifetime prevalence for mood and anxiety disorders than men. And the prevalence of common mental health disorders tends to be lower in older age groups, and this is across both genders. Okay, so this slide is a snapshot of the people we were seeing in the London NF Psychology Service in December 2021. Now, it's just a snapshot of a moment in time, but I just wanted to give an idea of the population that we tend to be working with. And this graph shows the percentage of patients split up by diagnosis and age and gender. So on the y-axis, we've got the percentage, and along the x-axis, we've got categories of age. Note that the 16 to 19 category is fewer years than the others, which cover 10 years. And the blue colours represent NF1, so we have dark blue for men with NF1, pale blue for NF1 female, and purple for NF1 other. And the green colours represent NF2, so the darker green is NF2 male, and the paler green is NF2 female. And at this point, we weren't actually seeing anyone with schwannomatosis. So 90% of our work in this snapshot is with patients who are aged 16 to 50, although we do see older people too. And 15% of our work is with 16 to 19-year-olds. Now in the service overall, so everybody registered with the London service at this point, 70% of patients were aged 16 to 50, and 9% were aged 16 to 19. So you can see in the psychology service, we're seeing a disproportionate number of young people, really between sort of 16 and 30, compared with the service as a whole. In the psychology service, we're seeing about 75% of our work being with NF1 patients and about 25% with NF2 patients. Again, in the service overall, there are about 84% patients with NF1, 9% with NF2, and 7% with schwannomatosis. So we're seeing a disproportionate number of people with NF2 in the psychology service. And we are seeing 22% male and 76% female, 2% other in the psychology service. And across the service as a whole, we see 56% of patients are female. So again, we're seeing a disproportionate number of females in our service. Having said that, if you think about the previous slides and what we know about the prevalence of mental health problems overall, it may just be that what we're seeing, this disproportionate representation of younger people and more women, that might just be representative of how mental health problems are in the general population. So it's possibly broadly representative of that general population. So now I'm going to go on and actually go through some of the mental health difficulties that we see in NF1, NF2 and schwannomatosis. And I've tried to group them together in overall ways that make sense, but it's really important to hold in mind that many people we see might be experiencing more than one difficulty at the same time. Some of the difficulties might be quite chronic, and that people might also represent different problems at different life stages as well. And again, just to start with some patient voices on this. So things that patients have told us just generally about their feelings around these conditions. I feel alone, tired, loss of independence, self-esteem, isolation, anxiety, people do not understand, hiding the pain is tough, requires a lot of mental strength, not being able to control the disease. I had no feeling of control at all prior to Avastin. So again, really, really important to hold in mind what patients are telling us about their experiences here. So the first category I'm going to talk through is neurodevelopmental issues, and this is predominantly something we would see in NF1, although of course people in the general population can show these issues as well, so we might well also see them in NF2 and schwannomatosis. So one thing that we know is more prevalent in NF1 than in the general population is autistic spectrum disorder and attention deficit hyperactivity disorder. And this is particularly something that as patients mature, we might find people coming and saying, I think maybe I have one of these conditions. As people mature, we see there can be a relatively greater impact of the difficulties that these conditions cause as perhaps the demands of school and their social life get greater. We also know in NF1 that you're more likely than in the general population to have a specific learning difficulty. And I'm very conscious of using English language terminology here. So for specific learning difficulty in the UK, we're talking about a disproportionately low performance in one or more areas, but not a global problem. So we're talking about difficulties such as dyslexia, dyspraxia, dyscalculia, perhaps impaired processing speed, poor concentration or poor working memory. And again, this is something that might not be very apparent really early on, but as the demands of someone's education setting or their work setting increases, more problems might arise as a result of these difficulties, and people might start to find school and work increasingly hard. And then again, I'm conscious of using English UK terminology. We have learning disability. So learning disability in the UK is diagnosed as a global pervasive developmental difficulty across a lot of domains, education, but also perhaps some difficulties with independence and activities of daily living. And ideally, this is diagnosed prior to adolescence, but in cases where the learning disability is mild, this might be missed, and we do sometimes see a young person might leave statutory education with no qualifications and no support. So it's really important to hold in mind that many people with NF might need support in education or work in order to fulfill their academic potential, and also to help them properly integrate with their peers and build meaningful relationships. Now I want to think about the impact of having a physical health condition on people's mental health. And again, here are a couple of quotes from patients. Inability to participate in physical activity is frustrating. And this other quote from someone with NF2 who has also lost their hearing, but who says, losing balance, leg strength, eyesight and independence is the problem. So many of the people we see have chronic pain, and this can be a very disabling and distressing thing to experience and have a really big impact on quality of life and hence mood and mental health. A lot of the people we work with have sensory or physical disabilities. So for example, people might often have poor vision or be registered blind, poor hearing or be registered as deaf, or have impaired balance and neuropathies. And again, as well as the physical impact of this can have a very big impact on social life, independence, and again, self-esteem and mood alongside that. Many people have problems with their body image. In these conditions, there are a lot of objective visible differences. So visible differences that are not people misinterpreting their bodies, but are actually there for everyone to see. So things like plexiform tumours or short stature in NF1, or problems with balance and vision in NF2. A lot of NF2 patients have people assuming that they might be drunk because of the way that they walk and struggle with their balance. And people with NF2 in particular may have a facial nerve palsy that stops them from smiling and interacting with people. Sometimes we work with people who meet criteria for an eating disorder, and there can sometimes be quite clear links with their physical health disorder. So, for example, I've worked with somebody who said, well, if I weigh less, my plexiform might look smaller too. So that's a misguided notion, but it's a notion that's making this person want to limit and reduce their weight. And a lot of people of all ages reflect back particularly on maybe their first 20 or so years of life, and they've been bullied in their education settings and by their peers. Moving on from that, a lot of people report difficulties coping with the fact that this is a long-term health condition. So it's not something that we can cure, and in fact, in most cases, it's going to be progressively getting worse. So somebody said, I'm tired of all the procedures and surgeries. How many more can my body take? And a really common theme from our patients is not being able to control the disease. So we find ourselves doing quite a lot of work helping people understand the conditions. So in English, when we use the word tumour, medically we mean a lump, but a lot of people assume that a tumour means cancer. So we do a lot of work around explaining that that's not the case. And a really big factor in these conditions is they're very variable and they're very unpredictable. And that can be very hard for people to understand and to learn to live with. We do a lot of work around managing treatments, particularly in some of our younger population, things like understanding surgery and being able to consent to that, how to manage recovery. And a really common one actually that we see is around tablet taking. We see some people who really don't want to be having to take tablets every day. We see this quite a lot with some of our painkillers, and also some people who are taking tablets for epilepsy. I've particularly worked with young people, young men in fact, who after a while say, well, I'm very fit and healthy. I think probably my brain can fight the epilepsy by itself now, so I'm just going to stop taking my tablets. So working with them to understand how these tablets work and why we're asking them to take them every day. And then we sometimes have the opposite issue. People are experiencing a lot of pain, so a lot of people will try and manage this themselves, perhaps by paracetamol, and begin to take it more and more frequently. So working with people to understand the pitfalls of that and why that's not always the best way to be managing their health condition. We do a lot of work around transition. So in young people, in the UK, for example, once you turn 18, you're expected to be seen by adult rather than paediatric services, and that transition period is often sort of between the ages of 16 to 18. And for a lifelong condition, this can be quite challenging for a young person who, for most of their life to date, has relied on a parent to do the talking for them, and certainly relied on a parent to consent to treatments for them. So supporting young people to talk to their health team without their parents present, and particularly to think about giving informed consent and making sure they're kind of learning to take ownership of their health management. And then another really common theme in working with people with any long-term condition really is tolerating uncertainty. So intolerance of uncertainty is a transdiagnostic feature of a lot of mental health problems, and particularly anxiety. And moving on, we do occasionally have to think about cancer and end of life in our patients. So sometimes tumours are malignant, and we will try and work alongside cancer services who are medically looking after our patients, and we'll try and support patients through those interventions and treatments. And we might also find that tumours are benign, but they're non-treatable and they can become life-limiting. So particularly cerebral tumours in NF2. And again, we'd be working to support those patients. And we might also reach out to families and hope that we can offer them some support or signpost them to support, both as patients approach the end of their life and for families after a patient has died. And now thinking a bit more about the wider system, we're often called upon to help and to think about the impact of NF on family, friends and relationships. So here are a couple of quotes. This is a female saying, "I haven't been able to give him," her husband, "what I should as a wife, and I feel constantly guilty." And someone else saying, "In our family, NF is a bad thing and we avoid talking about it." So we often find people come to us at a younger adult age seeking understanding of the genetic implications of these conditions. They might want education about reproductive options, particularly if they've got a new partner and they're beginning to be at a point in their life where they're thinking about their own options for starting a family. We would want to support egg harvesting in young female NF2 patients who've been offered Avastin. A lot of time people coming to us and they're very anxious about how to tell a potential partner that they have a condition that's hereditary. And as I've shown in the quote, a lot of guilt about the impacts on partners and the family, in particular people who see that they've passed on the condition to their children. And there's often quite a challenging family narrative around NF. So in families where the NF has been passed down through a few generations, it can have a really big impact on patients when they look around and they see what NF has done with other family members and how the family has tried to talk about that or deal with that. And I should say, particularly on this area, this is not just a mental health professional's role. We get a lot of help from nurses, geneticists and other counsellors supporting all of this kind of information giving and helping patients with these decisions. And finally, I just wanted to think about mental health more generally. And here's a patient saying, "It's exhausting. Sometimes it's easier just to avoid everything." So we do see a lot of anxiety and low mood in our patients, and this is very, very common in the non-NF population as well. So this definitely isn't unique to NF. We see people with, for example, obsessive compulsive disorder, people with more subjective body image difficulties, so people who actually objectively look very well and they don't have external evidence of NF, but they might develop a body dysmorphia in their own worries about their body. We see people with eating disorders where, again, the links with NF might be quite unclear, but perhaps there's, for example, disordered eating in the non-NF parent. And as with any population, we see people who've experienced trauma or abuse, and we talk to people who are at risk, so at risk of self-harm, who are experiencing suicidal thoughts, or who are misusing or abusing different substances. And it's really important to hold this in mind, because for some of these people, the mental health support they get through their physical health team might be the first time they've talked about their mental health, might be the only professionals they've built up some trust with to talk about those difficulties. So even where we see these issues that might really not be very linked with NF, it's really important to be aware of them, to think about them, and to show patients that we treat them as important and we're going to help patients get some support with them. So overall, people with NF do report a huge range of neurodevelopmental and mental health difficulties. A lot of these, as I hope I've shown, can be understood in the context of the physical health condition, and some might well develop for other reasons, but they might have an impact on our patient's physical health, or they might be impacted themselves by our patients' physical health. So for the final part of this, I now want to think about how we can best support mental health needs in our patients and families. And I'm going to show a couple of models of how this might work, and also think about what skills and knowledge we can equip our whole physical health team with in order to make sure that this happens. And again, grounding this in what our patients are telling us, I do think the counselling service should be available to our immediate family. Someone else saying, I could have done with an independent person or service to talk to, but it was never offered to me. This was in the 90s, before the NF clinics were set up. It is so important professionals notice when someone needs that support. Someone with NF1 saying, it's because of the mental health support that I'm able to accept the physical support I need. Rather than the mindset of I'm not different, my physical and mental problems are part of this illness. And someone else saying, I think the challenges people with NF and schwannomatosis face need to be dealt with by people who understand the conditions. And on this slide, I've tried to demonstrate how we think this can best work. So looking out for our patients' mental health difficulties and giving them good support. So the first thing that's really important to stress is that this type of support needs to be lifelong as well. And even if someone doesn't have some mental health difficulties, we just need to be aware that maybe at some point further down the line, they might have. And so this is something we need to revisit. So a really important part of what we can all do is ask about mental health at every visit. And I'll go on and expand on how we might do that in a minute. It's also quite key that all clinical staff should be able to signpost or give helpful information. So we don't all have to be trained and be expert in mental health, but we should be able to know what other resources are around and to have some open conversations with our patients about how they might get some more help. I think if it's at all possible, it's incredibly useful to embed a psychology service within your physical health clinic, and I'll go on to talk a bit more about that. But it's also really important to know what other specialist mental health services you have around you in your health system and foster really good links with those services so that you can refer into them when the mental health issue is different or too great and really needs to be looked after by one of those specialist services. And alongside all of this, it's very important to manage mental health risk at every stage, and I'll talk a bit more about that as well. So thinking now about the concept of lifelong support for patients and their families. So first of all, thinking about the moment of diagnosis, and of course this may be at a young age, or it may be at a later age, but it's important to have a multidisciplinary approach which includes psychology and mental health thinking so that we can stabilise and support the family right from the start. Sometimes it's really nice to have psychologists in the team, not because we're trying to pathologise or focus on things that are wrong, but actually to promote resilience, to talk about what strategies and strengths that family or that person has, so that we can build on them and keep them going. When someone reaches young child age, it's really important to do a developmental and neuropsychological assessment, perhaps around the age of 4 or 5, and this can help detect any delays and therefore start any interventions at a useful time. And then throughout childhood, again, it's really useful to have regular assessments. This might include neuropsychological assessments at various times, depending on what the child's needs are. And then again, if we discover that there are some needs, we can put in place counselling and interventions to try and reduce any educational disadvantages and promote support in those educational settings. And also thinking about peer relationships that the child's developing. So things like promoting emotional recognition and regulation and helping young people integrate well with their peers. As the person gets older, we'll just start with a couple of quotes here. So somebody saying, in my teenage years, I decided that if I didn't fit in, I really would not fit in and not try and keep myself well or try to do well. And someone else saying, I have also had little self-worth and have put up with horrendous relationships just so I have someone, just so I fit in and meet social norms. So thinking about what we offer to teenagers or young adults, I've already alluded to how we support transition to adult services, but again, really keeping that focus on how NF can impact on social life and relationships. And as the school setting gets a bit more demanding, and making sure we're supporting patients with their friendships and things like bullying and important exams that they might be sitting. And then right on into adulthood, we might be thinking about how we can support people in work, fostering independence, helping with relationships, and all those things about living with a long-term condition and starting their own family and just having those ongoing medical and emotional needs. So, really thinking about the whole lifespan of the patient and how we can be there at all the different points through it. So earlier I mentioned the concept of asking about mental health at every visit. And this is really important, and any clinical staff can be trained to feel confident to do this. This is simple questions like, how are you feeling about all of this? Are you okay? How are you doing? Or you can use screening tools. So these are some common ones in use in the UK, the GAD-7, the PHQ-9, the HADS and the CORE-10, and I know that some of them have validated translations into other languages. And it's really important because if someone's just having a quick visit to the clinic and they're only seeing one or two professionals, again, this might be a really key chance just to check in with their mental health. You don't need specialist training or knowledge to ask these questions, and it helps normalise and validate the experiences that these people might be going through and can open the door to offering them a bit more support. So following on from that, it's really important that we build staff confidence in talking about mental health. And this is just an example of some skills that actually probably everyone has, but may not have thought about using these skills in relation to mental health. So things like active listening, being attentive, being non-judgmental, really giving time, not rushing somebody and really showing that you're listening. Validating the issue, so saying something like, it's completely understandable that you're feeling like this. Normalizing can be really, really powerful. A lot of people assume that they are the only person to feel in a certain way, and they can feel very lonely and a bit strange. So being able to say to someone, it's quite common for people with NF to feel like this, or lots of people tell us they feel like this, that can be very reassuring for a patient to hear. Notice people's strengths. So as I said earlier, having a mental health professional in your team or working whilst thinking about mental health isn't always about picking up or asking about difficulties. It can be really helpful to notice when things are going well and to talk about that. So saying something like, you did really well to make it to clinic today when you're feeling so rubbish, or it's great that you've been able to explain this to me so that we can try to help. And last but not least, it's important to give people hope. So something like, I can see you feel very low, but there are lots of things we can do to help you with that. So another thing we can equip all staff to do is to know where to signpost to, where to send people to, or what written information we can give them. Give people written information about their physical condition and about their mental health need. And for some people, this might be all that they need, and this might be just at the level where they can go away by themselves and have a read and have a think. So the web link here is a really lovely UK Health Service English language self-help site with a range of leaflets about some really common mental health difficulties. And I've put it in just because it's really useful if you have people who are confident in the English language, but also maybe to encourage people to investigate whether in their own countries something similar exists that they can call on. signpost to other health services. So it's really useful to know what else is available in your health service linked with your setting. What's the local therapy or mental health service, and how can your patients access them? So you might not be the right person to give the mental health support, but you can play a really key role in helping your patient access that support. So for example, in England, not the whole of the UK, but in England, patients can actually refer themselves to a local health service talking therapy. And have a look at your voluntary sector or any charities that work in NF. So in the UK, for example, we have Nerve Tumours UK, we have CTF, obviously, and we have a great charity called Changing Faces, which works with people with visible difference. So being able to point patients to these sorts of resources, which they may not have come across on their own, can also be really useful. I mentioned earlier the concept of embedding a clinical psychology service within your NF clinic, and I appreciate this may not always be possible, but where it is, it can be a really, really useful resource. It makes mental health work very accessible to patients. They're coming to the physical health team anyway for their reviews and their checkups, and they can see a psychologist at the same time. It normalises this concept that mental health care is an integral and important part of physical health care. They're not two separate things. It really facilitates communication and understanding within your multidisciplinary team. And it's a lovely way of modelling that there are so many links between mental and physical health rather than separating them out. And here's a quote from somebody who said, "When I have self-esteem issues about my physical self, I need support on that issue. It helps if they can relate it back to NF, as there is a better understanding." And all the patients we talked to emphasised how important it was for them that mental health professionals also understood their physical health condition. So in the next few slides, I'm just going to run through the types of interventions that a psychologist or counsellor in your service might then be able to offer. So some short or quite low-level interventions might be signposting, so just normalising the idea of psychology, giving out information, consulting to GPs, so family doctors or other professionals, or letting patients know about other local or voluntary services that they might find useful. It can be very useful to do some psychoeducation, so some teaching around the condition and around the mental health impacts. So taking the time to understand what the patient or the family doesn't know and working with them to find answers. Another thing we do quite a lot, particularly with our younger population, is to manage information seeking. So really helping them be careful about how they use social media and the internet and making sure they're finding their information from reliable sources. I've talked a lot about transition, so again we can meet with the young person and sit in on transition clinics and support that change. And we can facilitate a lot of peer support. So in our clinic, we try and run patient groups, and there's scope to run family support groups and help people meet other people in a similar situation, which can be really powerful. And now thinking about some psychological interventions that might be a bit longer or higher level. So just thinking about neuropsychology, we can establish baseline cognition. With repeated assessments, we can look at whether there are changes in cognition. We can offer strategies and support around this and do a lot of liaison with education and work settings about how best to support people and overcome any difficulties. We can offer talking therapies. So in our service, for example, we often offer cognitive behavioural therapy or acceptance and commitment therapy. This would tend to be one-to-one and fairly time limited. So we would have a set of sessions, we would formulate the issues, so kind of work out what factors were influencing them and what impact they were having. We would agree some goals and we would work towards them. And then also in our service, we occasionally offer some longer term supportive work. And this particularly happens with some of our NF2 patients pre and post surgery. So kind of supporting them through that change and any sort of physical difficulties that might arise as a result of that. And another really important part is when we aren't the right people to be offering this support, so recognizing when the mental health needs require more specialist input. So typically, in some examples in our service, might be if someone has an eating disorder, if someone is actively experiencing psychosis, if someone is suicidal or self-harming. We wouldn't look after that within the NF service, but we would do a lot of work to liaise and refer on to a local mental health team that had the specialist knowledge to help that person. I mentioned as well that managing mental health risk at every stage is really important. So many patients who we see have periods where they wish they were dead, and most don't have active plans to hurt themselves or to act on these thoughts. But many say to us, you know, I just wish I could go to bed one night and not wake up the next morning. And these are difficult thoughts for people to be having, and it's really important that we ask about them and that we know what to do to support patients with them. But this can be really quite frightening for people who aren't used to asking those questions. So I think it often gets avoided by health professionals who are worried about what to do if they hear the answer. So it's really important to train and build confidence in the team around this. You know, people can feel really low, and we need to be confident to ask directly about suicide, self-harm, and risk to others. There's some really good training available to staff who aren't mental health professionals, but to help them feel confident asking these questions and knowing what to do with the answers. And certainly in the way the UK health system is set up, we have an amazing psychiatry team around us in our hospital setting, and they will come and help us if we're worried about a patient. And we can also work really closely with a local general practitioner or family doctor to keep the patient safe. And last but by no means least, we can do a lot of liaison and consultation. So we might work a lot with educational work settings and particularly counsellors in those settings. So helping them understand the impact that NF is having, but then they can deliver a mental health intervention to support the person. We might ask for educational psychologists to assess and support with learning. As I've just mentioned, we would work really closely with family doctors and local teams to manage risk, and we would do a lot of referring on where we needed to. And this is just an example of how the health service is set up in the UK. So we could refer to child services if the patient is under 18. If they're over 18, we have primary care, so local talking therapy, and then we also have more specialist teams that can support patients with specific difficulties, like, for example, an eating disorder. So it's a really useful part of what we can do is to know about those other teams and services and help patients get the support that they need. So for the final few slides, I just wanted to give some examples of how this can work in practice. So this is quite a busy slide, but I'll just go through it steadily. And this is how our psychology service is set up and embedded within our NF clinical team. So at the top level, level 1, we encourage all staff to ask those questions about mental health at each visit. So do you feel worried or low? How are you doing? And if the person says no, then fine, we don't need to act further, but we are aware that that answer can change, and we will ask those questions again next time we see the patient. If the patient says, yes, actually, I'm feeling a bit worried or low, again, we've got all staff feeling confident to do those active listening skills, to normalise, to empathise, to perhaps give some written information, and perhaps explain to patients that they can find some talking therapy locally and explain to them how to do that. Now, if the patient tries this and they're still distressed, we can go up a level. So one of the things we've rolled out in the last couple of years is group interventions, which are run by a psychologist, but also a lot of the rest of the MDT, particularly nurses and physios. And we cover things such as stress management, living with a long-term condition, healthy living. And it's tailored to NF, but it's not tailored to the individual. It's a group intervention. Now, if this doesn't improve, or if the group just isn't going to be suitable for that person, we would then offer some more intensive intervention, one-to-one work with a psychologist that's tailored to the individual. And again, if that doesn't help the patient or help them enough, we might take that to our supervision and we would think about some more specialist intervention or referring on to another mental health service to get them some more help. And this is just trying to think a bit more broadly, because not everyone could have that set up in their service. So just thinking, in the centre of all this, we have the patient and the family. And the patient will have a family doctor, and they will have probably an education or a work setting. And once it's established that they have NF, they will have a physical health team looking after them within some sort of hospital or care setting. So far, so good. But what's missing from the picture at the moment is that thought about mental health and the full picture. So if we're able to have an NF psychologist embedded in that team or as part of that hospital setting, that's another dimension of help that the patient and family can have. And the NF psychologist might be a really useful bridge to helping the patient and family access that more specialist mental health support as well. So, in summary, I hope I've got across this concept that mental health and physical health really go together, and therefore many people with NF will have mental health needs throughout their life. The mental health needs can be addressed and assessed as part of a large multidisciplinary team, and in collaboration with families, with the education sector, with other mental health teams, and with the voluntary sector. And I think it's really, really important that we build mental health assessment and care into the interactions that we have with our NF patients and families. And the last word quite aptly goes to one of our patients who says, if professionals could just stop and think, if this was me, what would I need? How would I be feeling? How can I make this time right now just that little bit easier? It would make a big difference to us. So thank you for listening. Thank you to our patients and families who teach us so much. And I've left our emails at the bottom here. We're very happy for anyone. If you're not able to take part in the Q&A right now, do get in touch with us with any other questions. Thank you.
Plečko, thank you so much for joining us for this very exciting moment for the NF community. What is really fascinating is that both of you are spanning different age groups. I would like to ask you if you could talk a little bit about this, the different approach for these different age groups. So maybe Dr. Henley, do you want to start maybe saying talk about his approach?
Thank you. So in my setting, I cover anyone age 16 or older. And by this stage, some of the things that we've talked about in the presentation have already been found and noticed. So much of our work is therapeutic and helping people learn to live with what's going on for them, manage things like anxiety and mood, and understand and tolerate what they're living with for the rest of their lives at this point.
Dr. Plečko?
Yeah, thank you. I mainly work with younger children, actually from birth until the age of 16 to 18, like that. And we, of course, due to this early age, we deal with the phase of diagnosis. And I think Susie already mentioned a number of issues regarding the emotional challenges around the phase of the diagnosis. And the burdens also for the parents. And the second aspect we here mainly focus on is an especially neuropsychological focus, meaning that we work on the neurodevelopmental aspects throughout this age span and try to counsel the patients and the parents how to best deal with the challenges because of neuropsychological deficits in some areas in everyday life.
Okay, thank you. So we're getting some questions here. Lars Eriksson is asking, can you give an idea of the range of severity of ASD condition in adolescents with NF1? How prevalent is ASD? Is it typically mild or extreme or between, and so on? So I don't know who of you would like to take that question. I don't know exactly who to ask this question to, but let me start with Dr. Henley.
Yeah, so I don't know the prevalences off the top of my head, but certainly we do see a real range of this. We see some people who wouldn't meet formal criteria for ASD the way it's assessed in the UK, but are definitely showing difficulties with peer interaction and socialization, and that they need some support around. And then we see other people who definitely get that diagnosis, and alongside getting the diagnosis, they then perhaps get a little bit more support from a specialist ASD service to help them manage with that. So definitely we see a big range of people on that spectrum.
Dr. Plečko, would you like to add something to that? Or
if I may also comment on that, I think recent studies talk about a range of 15 to 20%, so it's about 10 times higher, I think, than in the normal population around that. But there's also a big debate, I think, going on whether this is an NF-specific behavior, or if, as Susie said, really the criteria for ASD are met, and if it's a separate form of disorder or just an NF-specific phenotype.
Perfect. Another question from Armel Pindon. Could we identify predictors of quality of life as a primary outcome of family and a child with NF? Dr. Plečko, would you like to start with that one?
One of the most important predictors is probably, as in many areas, the resilience. And Susie also mentioned that in one of her last slides, that it is important to help the families to build up this resilience. And another aspect is whether there is whether it's a familial type of NF. So if the parents are affected either. I think the third aspect is probably the severity of the symptoms and the severity of the treatment the patients receive.
Dr. Henley, you want to add something, or shall we jump to the next question?
I think just one thing I'd like to throw in, because I absolutely agree with that. The one presentation we see where the objective severity of the symptoms doesn't always predict outcome is with visible difference. And in visible difference, often it's the perceived difference that the patient worries about that will predict quality of life. So someone with very few visible neurofibromas may be really, really worried and conscious of them. And conversely, someone with quite an objectively visible neurofibroma may actually have a lot of coping skills and a good support circle and manage that really, really well. So I think it's also interesting just to hold in mind with some symptoms, the subjective impact is more predictive of outcome than the objective impact.
And would there be subgroups of quality of life studies per manifestation? Would you be focusing and kind of say like, okay, for this manifestation, this is the kind of quality of life measures we're focusing on, or?
So we tend to use the INFI-QoL and the NF2-QoL, which were developed in English and validated in the UK, which tend to cover quite broad aspects of all those different presentations. I don't know, Thomas, if you use different outcomes in Austria?
Well, we use the German questionnaires, and we have broad, as you said, I totally agree. We have broad measures of quality of life with some NF-specific add-ons, but not really for different manifestations.
Okay, thank you. The next question is from Stephen Shirt. To what do you attribute the spike in service needs in middle-aged years? What issues are more prevalent in this age group?
So if that's kind of thinking back to the snapshot slide I showed, I would actually say it's a wider spike than that. I'd say we're seeing disproportionate numbers of 16 to 30-year-olds in our service, because bear in mind, the proportion of people in the service overall that I compared it to. I think it's probably because once people get older, they have managed to adjust and learn, and they are living with the condition a bit better. So coming up to being a teenager and then a young adult, those are life stages where you're trying to be independent, your brain is hugely developing, and then you're trying to maybe start your own family and start relationships. So I think it really makes sense that so many of those issues come up at that point. And hopefully, by the time people have moved on to a later life stage, they've had some support, and also they've developed their own coping strategies, and that's perhaps why the proportion then falls again.
Thank you. So I think there's two questions that I think are really interesting. Is how do we manage to help people with limited resources? And I think having two people from very different countries here would be interesting to get the UK and the Austrian perspective. So, Dr. Henry, do you want to start with UK perspective?
Yeah, I think this is a really pertinent question given the pandemic as well, and certainly the health service here has been really stretched. We have good links with the charitable sector. So with you, with Nerve Tumours UK, with a charity called Changing Faces. So we do try and make use of that where we can. But I think sometimes we have to accept as well that we can offer time-limited interventions. So we're quite goal-focused, and we'd be quite specific with what we're trying to achieve. And we try and equip people to then maybe carry on a little bit on their own, building on that. And we don't have the luxury of some longer-term interventions that perhaps we might like to be able to offer.
Dr. Plečko, do you like to give the Austrian perspective?
Yeah, it's not much different. We also have a very good patients initiative, a very enthusiastic patients initiative, and they really support us in the general hospital here in Vienna, and they also try to spread across all Austria to find local partners, to find doctors, psychologists who can offer services in more rural areas, so that it's not just centralized in Vienna. And the NF Patients organization also supports us in doing our research, which often results in certain group interventions where we can offer services and simultaneously do our research regarding the evidence of these interventions. So that's really of a great support. But it's a big challenge for patients to find professionals who really know about the issues and the burdens of these families.
So I think we are getting close to the end, but I think a pretty pertinent closing question here is, if you have these limited opportunities, how do you measure your outcomes, and how do you know what you're doing is actually effective? And especially if you have to make these hard choices of doing something in a relatively limited time frame, what is that? How do you measure that?
So I think it's a really interesting question, because the presentations that we see are so broad that we've shown in the masterclass. So in our service, we use some quite common screens. We use the GAD-7 to screen for anxiety, and we use the PHQ-9 to screen for low mood. And we'll often use them at the beginning and the end of an intervention to see if there's been some reliable change. But if someone is coming with a visible difference, I might just ask them to self-rate how worried they are about that difference and how noticeable they think that difference is, and we might repeat those measures at the end of an intervention. And if someone is perhaps has some cognitive difficulties, I might just say, can you rate your mood out of 10 today? And we might do that session by session. So there's no one size fits all, which makes collating data challenging, but it's really important to find an assessment that fits with your patient and at least be checking in that you are doing something helpful.
And are you preferring pharmacological interventions over therapeutic interventions, or are you mainly looking at therapy interventions?
So as a clinical psychologist in the UK, I can only offer therapeutic, like talking therapies. I can't prescribe, but we would encourage patients to explore pharmacological interventions as well, maybe with our psychiatrist or with their family doctor. And I guess we wouldn't always be able to tease out the separate impacts if someone was doing both those interventions at the same time.
Dr. Plečko, do you want to add a last thought to this? We are at the hour, but I just want to give you the opportunity to maybe say something as well.
Thank you so much. I have the honor of the final sentences. Just probably two comments. The one thing is one of our core aspects here in Vienna regarding the services for the patients is our outpatient clinic, which is an interdisciplinary outpatient clinic where we have a regular screening of the patients, and this helps a lot. And then we can add, and this is the second aspect, specific assessments. We do in first neurodevelopmental assessment at preschool age, so around the age of 4 to 5 years, and we then have a follow-up assessment at school age, where we focus on different aspects with classical neuropsychological tests, and this helps us in between, or these two assessments help us in between to counsel the patients regarding school integration and all the different also emotional aspects throughout their lives. Yeah, thank you.
Well, I would really like to thank both of you for this fascinating intervention today, and I would like to close the session with this.
Thank you.
Thank you so much.
Thank you.